Hello, everyone. I'm Thomas Johnson. I'm Executive Director of the Alliance to Save America's 340B program, or ASAP 340B. I want to thank everyone for joining today's webinar called Certainty for the 340B program ASAP, a deep dive into ASAP 340B's policy principles. Today's conversation will focus on the policy solutions that are needed to save the 340B program so it works for true safety net providers and the patients they serve. I'm happy to introduce our esteemed panel of speakers. I'm joined by Vacheria Keys, who is the Director of Regulatory Affairs at the National Association for Community Centers, also referred to as NACHC, the advocacy organization that supports community-based health centers. We're fortunate to have Vacheria join us today to share the perspective of covered entities across the country. We also have Jen Laws, the President and CEO of Community Access National Network, a nonprofit focused on public policy issues related to HIV, AIDS, and viral hepatitis. Jen is a strong advocate for patients and impacted communities, and we're lucky to have his voice in the discussion today. And last but not least, we have Dan Neves, the Director of Federal Policy at Genentech Incorporated, an American biotech company. Some of Genentech's transformational discoveries include the first targeted antibody for cancer and the first medicine for primary progressive multiple sclerosis. We are thrilled to have Dan join us to provide input and as a manufacturer. So I'd like to start off first by sharing some background about ASAP 340B. We were founded earlier this year to bring together stakeholders from across the healthcare system to strengthen the 340B program and make sure it supports true safety net providers in the communities that they serve. The partnership consists of community health centers, patient, provider, and consumer advocates, and leaders from the biopharmaceutical industry. The intent of today's discussion is to have a conversation about who the 340B program is currently working for, and the improvements and policy changes that are needed to see it restored to serve who is intended to serve, America's safety net providers and the patients that they serve. Before I turn it over to our panelists, I'd like to go over a few housekeeping items. We will be holding a question and answer portion towards the end of the webinar. If you have a question for one of our panelists, please submit it to the Q&A box at the bottom of your screen. If we do not get to your question, we'll follow up via email. In the chat, you'll also find a link to the ASAP 340B website and social media channels. We encourage you to visit these platforms after the webinar to learn more about our organization. And lastly, today's webinar will be recorded for educational purposes. With that, I will turn it over to Vacheria Keys.
Thanks so much, Thomas, and it's really a pleasure to be here today. And I think NAC, so the National Association of Community Health Centers, really appreciates the partnership with pharma as well as our other partners in ASAP 340B and the manufacturers. Just to give a little bit of a background of kind of how we got here with ASAP 340B, NAC approached pharma towards the end of last year when we felt like the year was really going at a very slow pace when it came to the federal litigation around contract pharmacies and really looking for solutions towards what does a stable program look like. And we tried to work within the existing 340B coalition that NAC was a part of with other covered entity groups. And we understand that all covered entities are not impacted by the contract pharmacy disputes as much as health centers. But the impact on health centers and being caught in the crosswires between manufacturers and hospitals really put NAC in a position that we had to put our members' priorities first. And to do that meant that we went to the other side to see how we can find compromise and not stand in this constant state of back and forth and really just kind of being at odds with each other, because there was a time before the contract pharmacy disputes that covered entities and manufacturers were on the same page and we were all rowing in the same direction. And the way that we get there is not by staying in opposite sides of the corner and pointing fingers. It's really about having uncomfortable and difficult conversations where we realize that it's not just health centers getting 100% of we want. And pharma and manufacturers realize it's not about them getting 100% of what they want, but how do we come together to benefit our patients, knowing that this program does work to benefit our patients, but the growth of the program, how healthcare has changed over the last 30 years, really does impact how are safety net providers able to take advantage of the 340B program, to use this program the way it's been intended, and to make sure that the patients who deserve access to affordable, respectable, and accessible services are able to receive that and affordable medications as well. So through our conversations with pharma is how our policy principles came together. And I want to just encourage folks to understand that these policy principles are not written in stone, as in they will not grow and be shaped as we transition to developing a legislative proposal that we look forward to working with members of Congress on. But these policy principles represent a starting point and a conversation about what does it look like to reform the entire 340B program, a program that was created in 1992, before we had managed care, before we had retail pharmacies participating in the program, before PBMs, all these dynamics that have changed the healthcare system around 340B. I think it's fair to say that this program, after 30 years, can take a tune-up. And so our policy principles represent areas that we have alignment on when we talk about PBMs, when we talk about how patients benefit in the program, but then our policy principles do touch on those sticky points where we are on different sides of the perspective on how we see patient definition, how we see contract pharmacy. But at the end of the day, the goal is to preserve and protect the 340B program. And the way that we do that is through realistic and compromising solutions. And compromise happens on both sides of the equation as well. So I'm going to walk through the policy principles. If you have questions, please feel free to put them in the Q&A box. I'm sure we'll have some time at the end to address them. And if always, feel free to reach out to me if you would like to have a conversation more in depth. And the last thing I will say is that we have been taking in a lot of feedback around the policy principles, and they are going to be reflected in this legislative proposal that ASAP 340B puts together. So, there's no policy principles 2.0. We're just simply moving forward in this process, but we really appreciate all the feedback that we receive, because that is how we shape and grow this proposal so that all covered entities can get on board and support this proposal. So, when we talk about what makes the 340B program and the true safety net, we're talking about providers that really depend on 340B savings and depend on access to affordable medications to provide those medicines to their patients, but also reinvesting those savings into their clinic or their hospital to serve those patients. So true safety net providers, I often say, everyone likes 340B savings, but do you need 340B savings? Because I can say from the health center perspective, our health centers need 340B savings to fill the gaps and stretch those scarce federal resources like our 330 grant to really meet the needs of our patients. And if we want to have a real conversation about 340B, we all can recognize that there are entities in the program that are benefiting more than they should from the 340B program. And so when we talk about prioritizing underserved communities, vulnerable communities, we're talking about true safety net providers that are not looking to make a lot of profit. They are looking to have the resources they need to meet their community's needs. When we talk about making sure that medications are affordable to our patients, I do not think it's too much to ask to say that you are in a program where you have access to discounted medication and patients are able to access those medications at an affordable rate. And we can have a lot of discussion about, should that be a sliding fee scale? Should it just be a patient assistance program? That's the feedback we're looking for. But if you are in the 340B program, it does not seem too far-fetched to ask that there is a guarantee that you as a covered entity have a program, have a system to make medications affordable to the patients. And that is also accessible to patients, that they don't have to jump through hoops to receive those discounts and to receive discounted services or medications. When we talk about patient definition, I can say this is an area where manufacturers and covered entities have to do a lot of work to come to the middle. It looks very different of how covered entities see patient eligibility and patient definition and how manufacturers do. And so we've been doing this work behind the scenes to really think about what is a patient definition that meets all 340B stakeholders' needs? Because at the end of the day, to address the gray area in patient definition that I know covered entities feel of, we would like a little bit more clarity of what HRSA is looking for. Manufacturers want safeguards and boundaries around who is an eligible patient and how does that eligibility work over time. And so these are areas now that as healthcare has expanded, when we talk about telehealth, when you think about referral systems and you think about the growth of the program, how do we have guardrails on patient definition as that connects to so many other areas in the program? And that leads us to contract pharmacy. Patient definition and contract pharmacy really go hand in hand when thinking about which patients are able to benefit from this program, but also how you increase access to affordable medications through contract pharmacies. And so as we know that contract pharmacy is a big reason why health centers are at the table, health centers use contract pharmacies more than any other provider because more than 50% of health centers cannot even afford to have an in-house pharmacy. But we know that 90% of health centers use contract pharmacy arrangements to benefit our patients that experience a lot of social drivers of health that are barriers to care, barriers to them getting the services and medications they need. And so we are willing to have conversations about what does contract pharmacy look like with also the appropriate guardrails and safeguards to make sure that our patients have access to what our need, that manufacturers feel comfortable about contract pharmacy arrangements, and that we are all in agreement to also make sure that HRSA has the authority that they need to truly run the program, and that we all have the clarity we need around these tricky areas like patient definition and contract pharmacy. I think an area everyone on this call can agree on is that PBMs are gaming the system, and they are gaming the system of 340B, but they are gaming the healthcare system. And so we see all this appetite from Congress to address PBMs and their role in healthcare, but there's this whole nother layer to it when you introduce the 340B program and how they are skimming savings off the top and they're taking rebates as well. And so an area that we all can agree on is that PBMs are the only stakeholder in the 340B program without requirements. Manufacturers have requirements, covered entities have requirements, Medicaid agencies have requirements. PBMs do not, and they're working with all these stakeholders. So how can we make sure that PBMs are held accountable and have requirements to be transparent and to also enter good business contracts is through legislation. And that's something that I think everyone can get behind. An area that is very important to manufacturers, and I think health centers stand with manufacturers in this area to say that hospital eligibility and how hospitals participate in this program is worth a conversation. Hospitals are 78% of the 340B program. Health centers are 5%, Ryan White clinics are 5%. The other proportion of hospitals is, I think, less than 7%. So when you think about where a lot of the concern and issues that have arisen in 340B, we have seen it play out in the media, it falls in this hospital eligibility section. And that also talks about child sites, right? There are areas of this program that are not fully fleshed out in policy and in regulation or in statute that are concerns for manufacturers. And so how can the hospital community come to the table to have these conversations with manufacturers about what is hospital eligibility to look like, that those true safety net hospitals that are really serving a lot of Medicaid and uninsured patients who are really prioritizing their patients' needs, how do we make sure that those hospitals are able to participate and stay in the 340B program, and that all those child sites of hospitals are held accountable? And this is, area that ASAP 340B would love to have more feedback on from the hospital community. I have said this already. I am not a hospital expert. I clearly work at NACHC. And so this is a voice that we need on ASAP 340B. We really need to hear from hospitals on what are areas that HRSA can intervene and have more authority over child sites or hospital eligibility. We're really interested to follow that conversation. Another area that I think has been proposed in other legislation like Protect 340B Act about a clearinghouse. This is an area that we all can support of that, right now covered entities are submitting to 340B ESP. Can we all agree on a neutral third-party clearinghouse system that can really address duplicate discounts, that can be opened up to all payers so that there's one system that covered entities are submitting their data to, but it builds in the transparency that we're looking for and it builds in the accountability. So when we think about managed care, we have Medicare, the Inflation Reduction Act, we have all these different areas where covered entities are going to have to submit 340B data or identify 340B claims. Can we make that easy on covered entities and providers, but can we also make sure that there is insight into the program from HRSA, from manufacturer's perspective, and that is where we are in alignment on a neutral third-party clearinghouse, and just how do we get there and how do we operationalize it is something that we're definitely still having conversations about and invite feedback. When it comes to public reporting, I think that we have heard loud and clear from HRSA that this is an area that they would like to have more insight on. This was in the president's budget as well, where HRSA requested that they would like covered entities to report 340B data to HRSA. And so we are still seeking feedback of what does it look like to be transparent? What are you actually willing to report? Because at the gist of it, I think HRSA wants to know, what are you doing with your 340B savings? How does it serve the patients in your community? And then how do you reinvest those savings back into your hospital, your health center, your clinic? Because that is something that, we all are very proud of the work that we do in the 340B program. And how can we report that information so that HRSA is able to verify it, audit, to make sure that all covered entities, right, and 340B are true safety net providers, and you have nothing to hide because this is the work that you're doing. This is how you prioritize it. From the health center perspective, we are an open book as federal grantees on how we use this program and how we serve our patients. And NACHC feels that if health centers can be transparent and come to the table, that all covered entities should be able to be transparent. And the how and the what is still up for discussion, but transparency is something that the administration is requesting, Congress is requesting. And so we are pretty much following what are the trends that we're seeing when we talk about 340B reform, and data reporting and transparency are definitely at the top of that list. And then last, it's really thinking about how there's been a lot of action on the state level around 340B. And we are moving in a direction where we feel that this policy proposal, this legislative proposal that we're working on as a whole, should really establish the clarity that we are all looking for on the federal level. A lot of the state efforts have come out of the lack of clarity on the 340B program on the federal level. So if we get to a place where, this 340B 2.0 or 30-year tune-up addresses a lot of the gaps in the 340B program, then do you need the state laws? And so thinking about how do we enhance the oversight of the 340B program to make sure that there is a floor of all states and all accountability, and hoping that we don't need as many state laws because the federal 340B program is governed in a certain way. So I see some questions in the chat. What I will say is that it's really important to I think it's really important to approach these policy principles with an open mind. What I will say is that ASAP 340B definitely takes credit for all the policy principles that are now floating around DC. We gave everyone something to work off of, to look at, and we appreciate all the responses and all the organizations putting out their own policy principles, because we had to get the conversation started. ASAP 340B's goal was to change the conversation in DC, to create urgency around the need for a 340B solution and legislation. And every time another organization engages and responds to ASAP 340B's policy principles, we are moving the ball forward and having a realistic conversation about what does reform look like. And it's more than just what your organization wants and what benefits just your members or your providers. It's about all of us in the 340B community, but mainly how are we serving our patients and making sure that we're making the improvements to affordable and accessible healthcare and medications. And so, I will say it again, ASAP 340B is doing exactly what we intended to do, and that is to move the ball forward through realistic and practical solutions. So look forward to talking to you guys about that more, and I'll turn it over to you, Thomas.
Thank you, Vacheria. Now I will turn the mic over to Jen Laws.
Hey everybody, I'm Jen, pronouns he, him. As the CEO of Community Access National Network, I think it's really important to tell you a little bit about me, and then CAN's priorities in this is as I am a trans man living with HIV in Louisiana, and I used to live in South Florida. I live as a patient, and I have worked in a federally qualified health center funded by Brian White, which is the federal HIV/AIDS program. So CAN's focus, we are a national organization, and community access is really our big thing. We've done a great deal to partner with our provider entities that are covered under 340B of all types, whether it's hospitals, FQHCs, even private practitioners. And then we also partner with our manufacturer stakeholders, and part of our big job is to make sure that patients have a voice in this. Patients are not giant community groups with millions of dollars to lobby or anything else, and it's really sometimes hard to kind of crack open a door to get our voices and priorities heard. So demystifying 340B, a lot of patients are familiar with it. So when we interact with these folks on these other stakeholders, bringing patients into that is really our big end. You're never going to get to a patient-centered, much less a patient-driven solution, anything that truly impacts patients without patients having a massive voice in it. And that's one of the spaces that we've been really concerned about is where there's manufacturers talking, there's dish hospitals talking, there's contract pharmacies, there's PBMs, there's FQHCs, there's all of these folks, and your patients can get lost in that. So when we really engage and do this education level, there's a couple things that pop up for patients, and it's our job to make sure you guys get to hear this. So couple things, and we're going to bring it back around to the policy principles. A little bit of background is that in HIV, there's a very special carve out for a covered entity grantee in 340B, and that's the AIDS drug assistance programs. It is the only specific payer entity that is covered as a federal grantee. And prior to the ACA, you couldn't get covered access for antiretroviral therapies for the treatment of HIV. It wasn't possible. And the AIDS drug assistance programs, or the ADAPs, were the state level kind of Medicaid design style, but only for HIV and only for medication, that made sure we had that access. And that model is a beautiful, beautiful model. Because of that reinvestment, it is exclusively on making sure medication pass-through is at a discount for people who cannot afford it at 400% of the poverty level or less. In some states, it's a little bit lower. We say it at 350%. I've seen some states grow it since the ACA because of reinvestments in those rebate dollars, and that's really kind of cool. We've seen expansion of support services, things like transportation, mental health, keeping people engaged in care if they have complicated health situations. If your priority is in transition-related care, as somebody living with HIV, having access to that is one of the #1 guarantees to make sure that I stay in care. So these are really kind of patient-oriented designs and ideas that we have behind it. And so when we talk about having that patient voice and having that patient priority, the #1 thing that comes up is charity care. Lots of patients are really familiar with our patient populations that are highly impoverished. We're really familiar with FQHCs, dealing with sliding fee scales and things like that. What they're also super familiar with is medical debt. Medical debt affects more than 2/3 of Americans. And when we talk about a vulnerability, we talk about impacting people's lives, their willingness to engage in care, to take care of their families in a way that feels truly accessible. Not, am I afraid of what this is going to cost me? Is that going to take food off my kid's table? Am I going to be able to keep the lights on? Charity care is the #1 thing that relates to medical debt. Because guys, this is gonna be hard for some stakeholders on this, and I really just, with open ears, the vast majority of medical debt in this country comes from hospitals. And that's hard. That's hard on my heart because you guys are partners. We're supposed to be working on this together. And I want to see solutions that come from this that has us addressing that issue. People will, when they have a negative experience with one provider, it's going to affect their willingness to engage providers anywhere else. And we can't call this a stretch of federal resources. We can't call it a healthcare program or any of that if all we're ending up doing is pushing people out of care. So I really like, if we can sit with that. I know lots of folks are, like, have big, strong feelings. They put their hearts into this work and everything else. And I want to honor that. I also need to remind everyone that as a patient advocate, my job is to speak for patients, and especially for patients that don't end up having that experience. And improving that relationship, discussing things like 340B as a tool to help us get there, to address things like health equity issues, these barriers to care, things like transportation, things like pharmacy and provider deserts, hospital deserts, rural hospital situations, all of these things, maternity care, because the reduction in access to maternity care is ridiculous. These are things that are wildly important to addressing things like the maternal mortality in Black communities. Those are really tangible and sometimes really hard to look at things. And everybody's kind of doing their best. And we are all looking out for our own interests. And if we can honor that and we can kind of come forward to that and recenter on our actual values, which is serving patients, then I think we're actually going to get there a little bit easier. And some of these hard conversations won't actually be that hard. So that is the thing I would really like folks to, like, in this space, and as we move past this space and in more detail in developing what a solution looks like, is to remember that this isn't going to be that hard if we're actually aligned with our values, if there's a level of integrity, because integrity is defined as integrating your values with your actions. So, like, let's have some integrity on that together. Call me out, call our partners out, let's call you out, like, let's do the thing. But there's no reason for throwdown, because if this is about furthering care and making sure people have access to care and healthier families and healthier communities, we're going to get there together. So 340B plays a critical point for HIV, and HIV is the only pandemic that was circulating at the same time as COVID. So we've been dealing with this pandemic for 40 years. And domestically, we're getting closer and closer to actually solving the epidemic relationship with HIV. We will not get there without 340B reform. We will not get there without addressing issues of health equity and barriers to care. And one of the coolest things I have ever seen is working with an FQHC that said under the Brown White Care Act and their funding there to say, hey, our patient engagement requirement is going to be met by asking how we should redesignate and reinvest our 340B dollars in this program. It was one of the coolest things in the whole wide world. I guarantee you, if you did a little bit more, everybody did a little bit more of that, we'd be a lot further along in this conversation. So that's really kind of big for me, because for some patients, reinvesting in that direct pass-through is really important. For some patients, being able to say, hey, we're going to start doing no cost, low barrier care. You come in for whatever's going on in your family that day, and you don't know how you're going to pay for it. You don't even have to fill any paperwork out. We're just going to take care of you because you're already a patient. Like, that is really kind of big, and it builds trust and relationship. For some folks, it was making sure that they opened a food pantry. Like, there are a lot of different things we can do with this that extend access to care that are meaningful. And if you talk to your patients, talk to your most marginalized patients and say, what do you need? If you knew how much dollars we had to be able to reinvest to make this program work, that isn't about the priorities of other stakeholders, then you'll end up serving your patients more. You'll end up having a stronger relationship with your patients. You'll end up growing your patient base. And you'll end up having, like, meeting those goals and metrics that feel really, really good. And you're still going to make a ton of money. Like, that's the thing. When you do the right thing with this, everybody's got room to make money. So that's like, if we refocus on our values, we're going to get there. 340B is the backbone that actually funds STI programs, HIV, a lot of our hepatitis C and substance use treatment. And that's, like, this is it. And we've got to clean it up. We've got to make sure that we're actually serving patients. So I really appreciate that. I think that I've kind of gotten to the point in our role in this.
Okay, thanks, Jen. And I just want to remind our audience, if you have any questions, please enter them into the Q&A box below. Finally, I'd like to get to Dan Neves with Genentech. Dan?
Yeah, thank you, Thomas. And, this is such an important issue for us as well. And it's just great to be part of the conversation today. So thanks for having us. I think there's so much to echo in the statements from Vacheria and Jen, especially the fact that the 340B program is vital to safety net providers and is an important tool to deliver, care in their communities. So, with that said, I just want to spend the next few minutes to share Genentech's perspective on the program and kind of what brings us to this conversation today. First, obviously, the program has, grown quite significantly over the years. It's quadrupled in size since just 2014 and now stands at about $44 billion in total discounts, making it the second largest federal program behind just Medicare Part D. And for us specifically, our 340B discounts, which are in the billions annually, they represent a very significant proportion of our total rebates and discounts. In addition to the overall growth in manufacturer discounts, we've seen a proliferation of dish hospitals and child sites, with the number of child sites alone increasing more than threefold in just the last 10 years, in sharp contrast to the relatively modest increase in other grantees enrollment over the same period. And while dish hospitals and child sites collectively make up a little less than half of all covered entities, the share of total 340B dollars going through those covered entities is about 80%. So quite a disparity there. But I want to be clear that those trends alone wouldn't necessarily be a problem. I think more concerningly, what we've seen with the evolution of the program is that some entities are not really using the program as Congress intended, and as one in the public would naturally think if described the 340B program. We're not the only ones that see those issues in that way either. Obviously, from our perspective, the recent articles like those in the New York Times and Wall Street Journal illustrated pretty well how the program is broken and perhaps even exacerbating health inequities in some communities. And in our view, a lot of those problems are due, like the root cause of those is a lack of transparency and oversight in the program, as well as a failure to ensure patients are more directly benefiting from it. And that's really what fundamentally drives our policy positioning around 340B. It comes back to how do we make the program work for those true safety net providers and their patients. But with that said, and I think Vacheria made this point too, we know that covered entities, be them grantees or hospitals, are not all the same when it comes to the program. And because of that, we're aiming to strengthen the program in a pretty targeted way. And that kind of leads me to our views on the program reforms and what we think it'll take to get this done. And I'll first say that the launch of the ASAP 340B coalition is, I think, a very needed and critical first step in the broader healthcare ecosystem. And it's really encouraging to see such a diverse group come together to protect patients and try to ensure the program's long-term viability. There's obviously a lot of work still ahead, from broadening the coalition, getting more perspectives, really hammering out the policy details, and finally pulling through an advocacy strategy. But we're really encouraged to see the stakeholders focused on a set of policy principles, many of which we as a company have advocated for a number of years. First, I'll mention transparency. You heard Vacheria talk a little bit about some of these principles, but I'll give you kind of our perspective on them as well. Around transparency, under the current program, it's very unclear how much of a profit certain providers are making off of the program, not just considering how many discounts they're getting, but also the markups that they have on insurers. And it's also unclear where those discounts are going. We also don't have a great sense of the mix of patients seen, especially at child sites, to make sure that those child sites are really serving the vulnerable patients, again, that you would expect them to under, as a participant in the program. And really at a time where transparency efforts are touching just about every aspect of healthcare, we think it's a pretty natural and important place to shed light here too. Secondly, around eligibility, again, among some covered entity types, and again, highlighted by recent reports and studies and so forth, we've seen some alarming practices, including expanding footprints in affluent communities, aggressive medical debt collection that Jen was talking about, and some very low charity levels of charity care. And to address some of those problems, we think it's pretty reasonable as a condition of program eligibility to start having a conversation about minimum requirements around levels of charity care, and making sure that child sites are truly serving those vulnerable patients, and they have a patient mix that kind of mirrors those of the parent facility as well as their charity care levels. And obviously, still on the eligibility piece, we think it's really important that patients are more directly benefiting from the discounts. So, for example, that could be extending to all covered entities, the sliding fee scale policies in effect for community health centers, to really ensure that patients aren't unduly charged for 340B medicines. In addition to the issues that affect us most acutely and ones that we've been tracking and supportive of for quite some time, are some other ones that are a little bit more recent and obviously affect community health centers in particular, and that's PBM pickpocketing. Obviously, this group knows that all those issues well, but just to emphasize, we also think that prohibiting those discriminatory actions can really ensure that it's patients and not corporate entities that are benefiting from those discounts. As Vacheria noted, we've seen a patchwork of state efforts in the absence of a federal solution, particularly in this area. And we think ultimately a more federal, solution, a federal solution is really what we need here. And then finally, in the conversation of like reform ideas, we think a lot about some of the trade-offs in this conversation, right? We understand that everyone would really benefit from clarity around some aspects of the program that HRSA has attempted to define and for which courts are now weighing in. And for that reason, for us, it's important that patient definition and especially contract pharmacy have a role or a part in the broader conversation. These are just a couple of examples. Again, I want to double down and say that, we appreciate the critical work being done by many covered entities that are participating in the 340B program, community health centers, HTCs, other grantees, as well as many hospitals. And we certainly appreciate the importance of the program to them. And that's really why we're focused on what I'll say are maybe comprehensive but targeted policies, focusing on the true problem areas that we've experienced in the program. Just to close out here, we recognize that everyone has aspects of the program that they'd like to see addressed, and our goal, and you heard Vacheria talk about this too, the goal of the coalition is really to keep an open dialogue and build some consensus. There always will be some areas where we may not completely agree, but there are probably more areas of alignment than not. And for us, we have longstanding commitments to our covered entity partners, HTCs, community health centers, hospitals, and so forth. And they're all important partners to us. And we really think that the strength of those relationships lies in our ability to work together on those positive policy changes. So we're just hopeful that through this collaborative partnership, a lot of trust and a lot of brainpower, we can kind of deliver on the changes to the 340B program and make it work a little bit better for providers and patients.
Thank you, Dan, and thank you all for sharing your insights. So we're going to transition now to the question and answer portion of the webinar. And as a reminder, if we do not get to your question, we will follow up via email. So Dan, let me start off with you. Some of your peer companies have pursued contract pharmacy restrictions. How does that align with pharma participation with ASAP 340B and align with the goals of the coalition?
Yeah, no, I appreciate the question, Thomas. I certainly can't speak to the actions of other companies. Not my place, probably not appropriate, but I'll simply say that we're here in the coalition trying to establish clear criteria around, how contract pharmacies should be used, how manufacturers should participate, and who are the beneficiaries of those discounts. So in other words, contract pharmacies participating in the program should have to provide the same kind of patient affordability, assistance that's provided by covered entities. But again, just more broadly, I think we know that the contract pharmacy issue is a huge source of uncertainty for many covered entities, and we think it's important part of any comprehensive reform to the program.
Okay. Next, I'll turn to Jen. Can you talk a little bit about, there are a lot of providers deal with patients that have or families that have multiple chronic conditions. Can you talk about the implications of a 340B program as it relates to that?
Yeah, so I gotta tell you, like, because of how Ryan White funded entities are in my particular patient population, this chronic and co-occurring conditions piece is really kind of important for us. We know that for our patient population, HIV will take 10 years before it develops into AIDS untreated, and that's not gonna kill me today, right? Like, but not getting my insulin or not getting my diabetes management or not getting cancer care, that is an immediate need. Not getting the mental health care that we need is an immediate need. So we're able to leverage 340B revenues. We see 340B revenues leveraged to extend these other pieces of care that are very, very important to our particular patient populations, and making sure that our patient populations are guiding, like that input is guiding what those support services look like, or those tertiary care, co-occurring condition care is really kind of important. Like getting that immediate community feedback really reflects on what that community needs in order to meet that metric and goal. So it's really important to keep in mind that about 1 in 3 patients who rely on 340B community health centers have a chronic condition and require very specialized care. And specialized care is costly to provide, whether it's the provider expertise or sometimes it's device management, sometimes it's very specific programming for those sets of conditions or what that community might face. Coming from South Florida, making sure that we had programming that was, and even living here in Louisiana, making sure that we had programming that met community need around storm preparation was a massive thing, and that we were able to see certain investments on that. That was also assisted by other state funding for emergency preparedness. So that's like that supplement and really extending it. It's super awesome. We saw it around reinvestment in helping kids get into schools and networking those school providers, those school nurses with the local FQHCs, so that a child that the FQHC provided their primary care, there was a through line there, that consistency in care was a massive improvement for those affected families. So that kind of thing is big for an individual patient. It's huge for a family, and it's immeasurably impactful in a whole community when it's made accessible. That brings that sense of urgency. Like, we're talking about 30% or more, depending on where you're at in a patient population for an FQHC or a community health center. That's important. That's like urgent. That's like, it'll give your heart palpitations, spend too much time on it, right? But that's indicative of the community's needs. And we got to meet those things. That's why we're all here. So our principals place the 340B program on a sustainable path. It's really got to be something that can continue to grow, not necessarily grow, but continue to meet the community need. It's got to be sustainable at that community level. And that means making sure our providers are well supported through this program as well, including meeting reporting requirements and things like that. So, and making sure that benefit is for patients and true safety net providers, those providers that are tangible to a community, not calling themselves safety net and not accessible to a community, because love y'all, we got to get on that. And that's like, when I mean that, I mean, I'm talking about rural hospitals. I'm talking about the trauma care, level 1 trauma care centers. I'm talking about things that cancer care for these impoverished communities. These things are truly, truly important. And we're seeing these reduce. When I was talking about maternity wards and infant care, that is consolidation in care, and that is restricting access. That's bad. It's bad. Like, that's not the point of this program. So making sure that we're extending those things in life-saving ways, life-affirming ways, quality of life improving ways for these communities is really where that piece is kind of important, and really how we end up seeing multiple levels of care, multiple condition, chronic care integrated in with that, like why we really need to see this move. So.
Okay. Dan, let me come back to you. Hospitals are taking most of the savings from the $44 billion that manufacturers provide in discounted drugs. What policy changes would you like to see to ensure that those savings are reaching patients?
Yeah, so thanks for the question. You know, I think I addressed earlier a number of policy ideas, and Vacheria did too, around medical debt, child site and hospital eligibility, as well as transparency and charity care. So I think hopefully that answered those questions. But I will also take this opportunity, and say that, we know hospitals, again, are not all a one size fits all kind of proposition. And there are a lot of hospitals that are already doing tremendous work to serve their communities. We're, looking at policies that would require all hospitals to behave the same way that some are already behaving. And we'd also like to see some of the requirements currently in place for grantees, like that sliding fee scale, for example, to apply to all covered entities. Basically, I think we're just looking for some consistency in how covered entities serve the most vulnerable, and how those 340B savings are available to those patients as well.
Okay, Vacheria, let me ask you. A lot of these policy issues, as we know, end up at the legislative level. We already know that a couple of weeks ago, there were a number of senators that issued a RFI to stakeholders regarding the 340B program. Give us your thoughts about, what are the next steps? What are the next steps with regards to this RFI, and what is the legislative path forward with regards to the potential policy principles that we've discussed?
Yeah, thank you for that. So I think we are encouraged by the group of senators that released a request for information, as they are, known to be very in the weeds on 340B and looking to how they can support the program and put the program back on stable footing. So I think ASAP 340B looks forward to the opportunity to engage and really talk about what is comprehensive reform. And so we will be basing our response off of our policy principles, but providing a little bit more meat on the bone of where we're really going when we think about our legislative solutions. And I think we all recognize that, right, ASAP 340B can put together this great legislative proposal, but it is simply that, a proposal, because Congress is really who has the final say, and the staffers are who has the pen in really drafting that legislation that hopefully will get introduced and passed, as we like to say in the health center world, soon and shortly. And so, this responding to the request for information is ASAP 340B's opportunity to expand on our policy principles, to demonstrate how we're looking at the 340B program from a holistic standpoint. And so we plan to do that. And we hope that other covered entities and other organizations take the same approach, because as we all provide our perspective to the senators on what we think the 340B program of tomorrow should look like, so that we can be in a program that all stakeholders are in agreement. I think it's important to note that we all are going to put all of our eggs in this basket and throw the kitchen sink at it, but hoping that they will take a little bit from everyone's proposal, and those commonalities that covered entities can agree on, the manufacturers can agree on, that other advocacy groups and patient groups can agree on, and that starts the building blocks of this proposal that we're looking for. But we all will have to comment on areas maybe that we don't love. but that's what compromise is. And so we hope that folks take that approach to it of like, how can you look at this from multiple perspectives, not just your perspective, not just what benefits your interest from your organization, but can we all take a step back and respond to this request for information with the 10,000 viewpoint look at it to say, what are other organizations going to say? What should I contribute to this? How can I show that our perspective on 340B has evolved? Because I think that's the work that we're trying to do through our ASAP 340B Alliance, is all of us showing how we can evolve and learn from each other. And NAC has, evolved from this partnership working with pharma. Pharma has learned from NAC. We're not saying that everything's done and we can go home, we're all perfect, but it is a growing season and we're all trying to grow and understand the other's perspective. And that doesn't mean that we don't have challenges along the way, but taking your ball and going home is not an option. So we are trying to work through those differences to respond to this request for information and continue our path of introducing or working with staff to get legislation introduced. And so we're continuing to work as quickly as possible. I will say it took us about 6 or 7 months to come up with our policy principles. So it is definitely not an overnight process, but that shows the work that goes into these conversations, is that it's not an overnight solution. It really is going to take time.
Okay, thanks. Jen, let me come back to you. How has ASAP 340B engaged with other covered entities such as hospitals who disagree with our proposed policy solutions?
So it's funny because we had a stakeholder meeting, I think last week or the week before, and we kind of all had a really good laugh by going, we don't all agree. And that's, I mean, one of the coolest things about how we've engaged with the ASAP as a group, or how the group engages, is that we will absolutely adamantly say from go, we don't expect everyone to agree, but we do need to find those through lines where we do agree and where things do need to move, or where if we see one group of stakeholders that are a little uncomfortable with maybe something that everybody else is in alignment with, then we need to square that up. Why is that? What is the investment? What is the incentive there that needs to be addressed? And if it doesn't actually align with the intent of the program, then we should probably have a very brief conversation about why that is. And those are hard. Those are, like, when we talk about hard conversations, that's what's happening in this space. So you don't have to agree. You don't have to agree to come to the table.
I just want to get Vacheria's thoughts about that as well.
Oh yeah. I think that we've been having a lot of conversations with a lot of covered entity groups around DC before NAC, or before we officially launched ASAP 340B. NAC approached all the covered entities that we were engaging with before in 2022 to let them know that this is the path we were considering, and giving everyone the heads up of, we are doing what's best for our members, and our members need a legislative solution. And that's what NAC was going to prioritize in 2023. I think now that ASAP 340B is public, we received feedback that we did this behind the scenes and it was a backdoor deal, but there was nothing to advertise until there was something to advertise. And once it was ready for the public. You don't tell everybody your business before you're ready to tell everybody your business. So we understand that folks maybe felt a little blindsided by our partnership, but now that it is public, we've had a series of meetings with hospital stakeholders, grantee stakeholders, and kept the door open for feedback. We understand that it took NAC and pharma 6 or 7 months, right, to come to this place. Our boards voted on ASAP 340B and there was a formal process. Others need 6 or 7 months, maybe 2, to come around. And so we've kept the door open from NAC, pharma, ASAP 340B to meet with stakeholders, to take in their feedback, to meet with their members. So we've had meetings with other organizations where we met with their 340B community or 340B committees, or we met with their leadership or their policy team. We've done a lot of meetings behind the scenes and really wanted to make this an open door process. And we continue to have this to be an open door process. And we're going to chat about ways that folks can also get involved and stay involved as ASAP 340B maybe is courting you to join the Alliance.
Right. And to build on that, I think that this just can't be a piecemeal approach. We have to come together to get this done. And if folks refuse to come to the table from their own perspective because they feel like we're going in the wrong direction, then we can't adjust to that. So like that's part of it. That's what makes this not a piecemeal approach, because we're trying to get as many folks to the table to find that through line that serves everyone.
And I just want to build on that. If you feel like the ASAP policy principles do not represent the hospital perspective, you are correct. For your perspective to be represented, you have to work with us. You have to have a conversation with us. You have to provide feedback. And like I said, we've had difficult conversations, but we are having the conversations, but we are looking for a hospital partnership. And that does not mean you have to sign on to ASAP, that day. But meaningful conversation is not just shouting your viewpoint into the wind. It's really taking in what the other side is saying and responding to that. And so we are open. The goal of ASAP 340B is not to kick out every single hospital. This is not saying that hospitals cannot join ASAP 340B. I know I've heard that feedback, and that's not simply our priority and goal, but to be included in the solution, you have to participate in the process.
Thank you, Vacheria, and thank you all for participating, and thanks everyone for attending our webinar today. Thanks for all of today's attendees. If your organization is interested in partnering with ASAP 340B, I encourage you to email us at info@asap340b.org, which can be found in the chat. We at ASAP 340B recognize that we don't know all of the nuances of how stakeholders interact with the program. So we want to be sure we have the right people at the table to get a better understanding of how the program needs to work better. For that reason, we are organizing listening sessions with some of the stakeholder communities, including federal grantees, hospital entities, and healthcare advocacy organizations, and corporate stakeholders like third-party administrators and consultants to hear more about how we can work together to realign the 340B program. Following this webinar, if you'll take a moment to complete the survey that will appear on your screen, we want to hear from you on if this was a helpful discussion, and please be sure to complete the survey if you are interested in those listening session opportunities. I hope you keep up with us by following us on Twitter and LinkedIn, which you can see on the slide here and also listed in the chat. And thank you all again, and enjoy the rest of your week.